Okay, so what we're going to do here is we're going to interview Dr. Richard Paulson, my favorite doctor. This is Kelly Snell from Creative Conception, and I have the pleasure of interviewing Dr. Paulson. He's the director of USC Fertility. He's also a professor of OB gynecology and chief of division of reproductive endocrinology and infertility breath at the University of Southern California Keck School of Medicine. Dr. Paulson has published several landmark investigations addressing the effect of age upon female fertility, including the first observation that egg donation could be used to extend the reproductive lifespan in women over 40. So what we want to cover today is the importance of screening of a surrogate. The bottom line really is to have a healthy body, a healthy pregnancy, and a healthy outcome. So the first question I have for you, Dr. Paulson, is to begin with, what does a surrogate medical screening consist of? And I know that could be several, but I have other questions too.
Sure. Well, thanks for having me, Kelly. And I think that what you said is really the important bottom line, and that is we all want to have a healthy pregnancy. We want it to go well, and whereas you can never guarantee that everything is going to go 100% the way that you would like for it to, we'd like to at least eliminate those things that would make it too risky for someone to carry a pregnancy, for example. And so the medical screening for the surrogate is sort of analogous to the medical screening of somebody who comes in who wants to have a baby herself. And that is, A, you want to make sure that person is healthy enough to carry a pregnancy. And then secondly, that their reproductive tract, meaning the uterus and all of that, is working in such a way that they are not predisposed to, let's say, miscarriages or problems during delivery. For example, women who have had a large number of cesarean sections are predisposed to having the placenta get attached to the cesarean section scar. So that would be a risk, for example, that's on the reproductive side. Whereas on the general health side, you would say, well, someone who has cardiovascular disease or has diabetes, they would then have a risk in their general health. So that's what we're trying to make sure. Let's make sure that we're healthy enough to be pregnant, and number two, that the reproductive tract can handle that pregnancy and take it to viability and to term, really.
Okay. So these questions we get, sometimes from surrogates, also is if she had a tubal ligation, would she be still a candidate to be a surrogate?
So absolutely, the key to surrogacy is that really all you need, since we were talking about the reproductive tract, is you really just need the uterus. And Kelly, I'm gonna take this plastic model.
Oh, great!
Just because I think that helps me anyway.
Yeah.
Patient. So that's the uterus here, and these are the fallopian tubes on the two sides, right? And those are the ovaries. And it turns out, and of course, when somebody wants to be pregnant on their own, they need all of those things to work. When somebody wants to be a surrogate, where we're going to be putting the embryo inside the uterus, they don't actually need the fallopian tubes. They don't actually need the ovaries either, because we're going to give them the estrogen and the progesterone. So tubal ligation is not a problem. In fact, we think that's great, because then we don't have to worry that that person is going to get pregnant on their own while we're perhaps anticipating getting them ready for the embryo transfer.
Okay. So we've had a case of a surrogate coming in for her medical screening, and in the evaluation, they thought the possibility that her tubes were blocked. So what would we do in a situation of that?
Yeah, so there's a special issue with blocked fallopian tubes. So like I said, if they're gone, that's not a problem. And then if somebody has blocked tubes and they're blocked right here, right next to the uterus. So just to explain this, right, the egg normally comes out of the ovary and is picked up by the end of the fallopian tube. And then the sperm swim from inside the uterus out to the end of the tube. So if the blockage is right here, right next to the uterus, that's just like a tubal ligation, or just like somebody who's missing their fallopian tube. So that's not a problem. We're going to put the embryo inside the uterus. The one kind of tubal blockage that is problematic is if the tube is blocked at the end. And I think that's what they're trying to show here on this side. This model has this big red poofy thing. That's because the tube gets filled. If you block it at the end, the tube will actually distend and will fill up with fluid. And that's called a hydrosalpinx. Hydrosal meaning water in the fallopian tube, hydrosalpinx. And the problem is that that fluid can then, make its way down the tube and it comes into the uterus, and it's toxic to the implanting embryo. And so those kind of patients need to have that tube either removed or need to have it at least blocked approximately right here in that area. So if there's a surrogate that has blocked tubes, but this would be very unusual. If she has blocked tubes at the end, that's really not good for her in any event. And then if she wanted to do it, then she'd have to have another procedure to remove the tube and block it proximally. But most of the time when you hear that a surrogate's fallopian tubes are blocked, really what they mean is that they can't, they're not getting the dye to go through on x-ray or something like that. And most of the time that's a proximal block, like a tubal ligation, and that is not a problem.
Oh, okay. You addressed this a little bit, but what are the reasons that most IVF centers have a guideline of 5 vaginal births and 2 C-sections for a surrogate to be a surrogate?
Yeah, I mean, so again, when you hear about women, of course, who have had 10 or 12 babies and they seem to be doing okay, the reality is if you look at the statistics, once you go beyond 5 deliveries, there's a higher risk of the pregnancies. The babies actually get heavier statistically for the first 3 births, and then they start getting lighter again. And somewhere around 4 or 5 is kind of I don't want to say ideal, but I would say that this is also not so much of an absolute rule. I think that's the rule that maybe can be bent in some cases. If someone had babies a long time ago and she never has any complications, a lot of those women do fine, but that's the answer. The answer is that they're called something called a grand multipara. That's one of these weird obstetrical terms, meaning that she's had a lot of babies, and we know that their subsequent deliveries are actually more complicated. 2 C-section rule, that it's actually a 3 C-section rule, so they can have up to 2. They can't have the 3rd one. When you have the 3rd one, you're not supposed to have any more. And that goes back for many, many years. I remember when I was in training, when a patient came in for the 3rd cesarean section, the old time professors were absolutely adamant that we had to do a tubal ligation on that patient, because that was it. You have a 3rd C-section, and then it's as though when you have the 4th C-section that, you will die or something terrible will happen. And of course, that's not the case, but it does get progressively more and more complicated to do the surgery. You're going through the scar time after time after time. So as a general rule, and again, I think you could individualize in that situation, but as a general rule, once somebody has had 3 C-sections, that uterus has had enough, and maybe we should not. Somebody else would have a better chance or a lower risk of pregnancy than someone like that.
Okay. And I think the last one was, how does BMI play a role in pregnancy rates?
Yeah, BMI, body mass index measure. It's really a measure of how tall and how heavy the person is, but it's kind of a surrogate marker, to use the word surrogate in a different way, for obesity. So really what we mean is if someone is obese, is that bad for them? And we tried long and hard to get our maternal fetal specialists to give us a cutoff, and they won't do it. But everyone knows that the heavier the prospective mother is, the higher the risk for obstetrical complications. And so most places have a cutoff at around 30, and some may go to 35 for the BMI. So again, what we're talking about is increased risk for the baby, increased risk for the pregnancy, and that is why that is why we have a limit, and we don't want the BMI to be. Our limit is 30. We don't want it to go above 30.
Oh wow. Okay. Well, I think that's what I have for today. That was very informative. Thank you so much, Dr. Paulson. I really appreciate your time.
I'm sorry you nearly choked to death in the middle of all of that. I hope it wasn't
No,
any-
it's allergies. That's all it does is allergies. Not sick.
Well, what I really want to say to the prospective surrogates is how much they are appreciated and how important their contribution is. There are lots of women that will make fantastic mothers who cannot carry the pregnancy themselves. Either they lost their uterus because they had cancer of the cervix, or maybe a postpartum hemorrhage and they lost the uterus, or they have a medical condition where they would potentially be risking death if they actually tried to become pregnant. So we are very thankful to the surrogates and very much appreciate them. And these medical screenings, really, they're just designed to try to keep everyone safe. They're not designed to, it's not like a test that you have to take. You have to jump through the hoop. It's not like an SAT test. We're really just trying to make sure everybody is safe. So we really appreciate it, and we appreciate you too, Kelly. We appreciate it.
Thank you, Dr. Paulson. I appreciate it. I hope to see you soon.
Hope to see you as well.
Okay, bye-bye. Thank you, everybody.